Initially, I was very excited about the title, and then I realized that I don't really know what I have to talk about. So I did what everybody does when doesn't know what to do. He goes into Google. Myth about hip replacement gives about 2,760,000 hits within 0.55 seconds. And I thought, wow, that looks good. And if you just click on those things, you will find out that most of them are by companies or by orthopedic surgeons who just pick up points which are really important for patients. Like, I'll have a permanent restriction after surgery. We know that's not true, but probably important for the patient. And there are also companies that go and make leaflets on myths of and realities about hip replacement. But I thought, well, that's not enough. So I went into the Oxford dictionaries and to look up what myth would mean. And there are two meanings. It's a traditional story, typically involving supernatural beings or events. So the word mystical comes from there. Or it's a widely held but false belief or idea. And I thought, well, Oxford is one important city in the UK, but there's also Cambridge. And they essentially come up with the same, a commonly believed false idea. So I thought maybe myth is not the right term we should use it for this talk, but I just put some facts or some thoughts together. So myth in the first meaning of mythological, an ancient story about natural events and facts. Maybe we have to put in this group, like in the 19th century, there was the belief that there's no treatment of hip osteoarthritis. So that people just had to live with that. And probably for the time being there, it is true, but now in retrospect, we know that's probably wrong because nowadays with increased knowledge and technology, we can do successful total hip replacements. But also in 1928, Girdlestone came up, the best treatment for a painful hip OA is femoral head resection. That was probably true for that time, but it's mythological today. And thirdly, something that is always true, in the past everything was better. That's also a myth that we can't, it's always true, or probably not always true. Now, a commonly believed but false idea. We have lots of those in orthopedic surgery. There's no problem with hip resurfacing. ASR has shown that there's a big problem. The hip resurfacing have been withdrawn from the market in the meantime. So that was a myth at the time. We know it was wrong. Hip resurfacing is functioning much better than total hip replacement. It's clearly shown that it's functionally not better. It has probably worse long-term results. And I think one very important, commonly believed but false idea at the time was that aseptic loosening was a cement disease. We know nowadays it's particle disease. So that was also a false idea, which we have proven that it was wrong. Now we have to be aware that myths are facts were facts in the past, and only with the present knowledge, those wrong facts can be unraveled. So nowadays we know what was wrong, and the future will show if our present knowledge is true or it belongs to the myth. So maybe this talk should be more on, not on myths, but on controversies in hip replacement. So there are a number of controversies in hip replacement. I picked the cup positioning as one, for instance. Short stems are better. Femoral offset has to be restored. Ceramic resurfacing will solve all problems. There are some points that we have been discussing yesterday. I pick up just those two to show some of my thoughts. Cup positioning, well, we all know the Levinic safe zone. We are told that an inclination of 40 degrees plus minus 10, antiversion of 15 degrees plus minus 10 is the safe zone, which will give us a stable hip without dislocation. It's a guidance. But there are coming more and more up publications like this one that show that depending on the approach, for instance, or if you look at those graphs on the left and the right, the majority of those hips that dislocate are in the Levinic safe zone. So this is probably questionable. What do we do with that now? What are the knowns and unknowns of for instabilities. We have prosthetic impingement, approach may be a factor, soft tissue tension, femoral head size. There are a lot of numbers which are important, and also cup positioning. But do we know enough about motion of the pelvis? This is the same patient, a young 25-year-old, she came for impingement problems. It's just an example. What's different positioning of the patient or motion during the day may act. On the left, you have a standing X-ray. And if you look at the anterior and posterior rim, you will see that she is over-anteverted. However, if she's supine, she has axial version. So she has a high mobility. And if we now place that silver cup in an anatomic position, well, I don't know which position is correct, where I have to put the cup. And this may be an answer why the Levenik safe zone is not correct for all situations. So the mobility of pelvis influences the positioning, and Levenik safe zone may be misleading. We know currently we are discussing it. We don't know if it's a myth or if it's true, but I think the future is more investigation will show that. And the other controversy I want to point out a little bit is the restoration of the femoral anatomy. We have this wonderful implant which has different sizes, different offsets, and by placing this implant into the proximal femur, we can reproduce almost every anatomy of the proximal femur. We know it has been shown, that has been shown by Babiš, for instance, in this book. We have seen this graph yesterday a couple of times. And all those short stems, not only the optimist, all the short stems, and many of the short stems are able to reproduce the anatomy. Now, if you have this hip on the right, it's a varus, a very high offset. How do we restore the anatomy? In the past, I've seen such things like that. They just a straight stem or a chloride type stem was used, put into varus. You can do this technically. But is this meaningful? Who would place a hip like this? We all know that so much in varus, it's going to fail. Now, of course, with the optimist, you can do this as well. It looks even better than that. But again, it's in varus. Now, the 2 years results show that we don't have a problem with that. We don't have an outcome of varus and valgus stem alignment is good. We don't have any loosenings. But we don't know what's going to happen in long term. So I want to advise a little bit against just putting the stem in a varus position. We know that the varus is risk factor for early loosening, although this paper I cite here is for cemented stems, but we need more long-term stems. And sometimes you just have to accept the fact that we cannot restore the femoral offset. And in my experience, patients with such reduction of offset do quite well. This is usually not the problem. So there are many controversies in total hip replacement surgery. The future will show which ones are true, and others will be identified as myths in the past. Thank you very much.